The subject of our lecture is symptomatic hypertension. Classification of arterial hypertension. What is a hypertension? Hypertension is systolic BP less than 90 and diastolic BP less than 60 hydrargyro. Normal BP. Systolic BP is 90 to 129 and diastolic BP 60 to 84 mm hydrargyro. Prehypertension, it is systolic BP 130 and 139 and diastolic BP 85 to 89 mm hydrargyro. Stage 1 hypertension, systolic BP is 140 to 159 and diastolic BP 90 to 99 mm hydrargyro. Stage 2 hypertension, systolic BP is 160 to 179 and diastolic BP 100 to 109 diastolic BP. Hypertensive crisis. Systolic BP more and equal 180 and diastolic BP more and equal 120 mm hydrargyro. Isolated systolic hypertension. Systolic BP more and equal 140. Diastolic BP less than 90. Isolated diastolic hypertension. Systolic BP less than 140 and diastolic BP more and equal 90 mm hydrargyro. Definition. Secondary hypertension, or less commonly unessential hypertension, is a type of hypertension which by definition is caused by an identical underlying primary cause. It is much less common than the other type called essential hypertension and affecting only 5 to 10% of hypertensive patients. Accounts for 70 to 85% of cases of hypertension in children less than 12 years of age. Age at onset less than 25 years or more than 55 years. Causes of secondary hypertension include endocrine hypertension. This includes primary hyperaldosteronism, Cone syndrome, most common cause of secondary hypertension in adults. Hypercortisolism, Cushing syndrome, hyperthyroidism, pheochromocytoma, primary hyperparathyroidism, acromegaly, congenital adrenal hyperplasia. Renal hypertension. This includes renovascular hypertension due to renal artery stenosis, polycystic kidney disease, renal failure, glomerulonephritis, systemic renal erythematosus, renal tumors. Coarctation of the aorta, obstructive sleep apnea, medication, sympathomimetic drugs, corticosteroids, non-steroid anti-inflammatory drugs, oral contraceptives. Recreational drug use, amphetamines, cocaine, phencyclidine. Isolated systolic hypertension, also cause of secondary hypertension. Recent can help you remember the cause of secondary hypertension. R is renal. E is endocrine. C is coarctation of aorta. E. Estrogen. N. Neurologic. Rise of intracranial pressure, stimulants use, and so on. T. Treatment. Corticosteroids and non-steroid anti-inflammatory drugs. Primary hyperaldosteronism, Cone syndrome. Causes of hyperaldosteronism. The condition is due to bilateral idiopathic adrenal hyperplasia, 6% of cases. Adrenal adenoma, Cone syndrome, 33% of cases. Primary adrenal hyperplasia, 2% of cases. Aldosterone-producing adrenocortical carcinoma, less than 1% of cases. Familial hyperaldosteronism. There are two types of this familial hyperaldosteronism. One of them, glucocorticoid remediable aldosteronism, is type 1, less than 1% of cases, and type 2, less than 2% of cases. Ectopic aldosterone-producing adenoma or carcinoma, less than 0.1% of cases. Genetics. 40% of people with an adrenal aldosterone-producing adenoma have somatic gain-of-function mutation in a single gene, KCNJ5. Other genes commonly mutated in aldosterone-producing adenomas are ATP1A1, ATP2B3, CACNA1T, and CTNNB1. Primary hyperaldosteronism can be caused by either hyperactivity on one adrenal gland or both. Unilateral disease is usually caused by aldosterone-producing adenoma and less commonly by adrenal cancer or hyperplasia. Bilateral disease is usually caused by bilateral hyperplasia. There are rare genetic syndromes like familial hyperaldosteronism type 1 and 2, which may cause both glands to be hyperactive. Pathogenesis. Aldosterone has effects in most or all cells of the body, but clinically the most important actions are in the kidney, on cells of the distal convoluted tubule and medullary collecting duct. Aldosterone helps control blood pressure by holding onto salt and losing potassium from the blood. The increased salt increases the blood pressure. Hyperaldosteronism is a disease in which the adrenal glands make too much aldosterone, which leads to hypertension and low blood potassium level. Signs and symptoms. High blood pressure is often the only sign of hyperaldosteronism. The hypertension is usually hard to control, and patients are often on 4 or more blood pressure medication. The hypertension may cause headaches, blurred vision, dizziness. While patients with hyperaldosteronism may have normal potassium levels, many patients may have low potassium levels. The hypokalemia can cause fatigue, numbness, increased urination, increased thirst, muscle cramps, muscle weakness. Hyperaldosteronism leads to an increased risk for heart attack, heart failure, strokes, kidney failure, early deaths. Diagnosis. Measuring aldosterone alone is not considered adequate to diagnose primary hyperaldosteronism. Rather, both renin and aldosterone are measured and result aldosterone to renin ratio is used for case detection. The diagnosis is made by performing a saline suppression test, ambulatory salt loading test, or fluorocortisone suppression test. Measuring sodium and potassium concentrations simultaneously in serum and urine specimens has been suggested for screening purposes. Calculating the serum sodium over urinary sodium to serum potassium over urinary potassium, and the serum sodium to urinary sodium to serum potassium ratio delivers calculated structure parameters of the renin angiotensin aldosterone system, which may be used as a static function test. Its results have to be confirmed by calculating the aldosterone-renin ratio. If primary hyperaldosteronism is confirmed by clinically, CT scanning or other cross-sectional imaging can confirm the presence of an adrenal abnormality, possibly in adrenal cortical adenoma, adrenal carcinoma, bilateral adrenal hyperplasia, or other less common changes. Imaging findings may ultimately lead to other necessary diagnostic studies such as adrenal venous sampling to clarify the cause. Differential diagnoses include essential hypertension, metabolic alkalosis, renal artery stenosis, malignant hypertension, preeclampsia, licorice intake, Gitelman syndrome, Bartter syndrome, adrenal carcinoma. Treatment. The treatment for hyperaldosteronism depends on the underlying cause. In people with a single being tumor, surgical removal may be curative. This is usually performed laparoscopically through several very small incisions. For people with hyperplasia of both glands, successful treatment is often achieved with spironolactone or eflalenone, drugs that block the effect of aldosterone. With its anti-adrenogen effect, spironolactone drug therapy may have a range of effects in males, including sometimes gynecomastia. These symptoms usually don't occur with eplerenone drug therapy. Hypercortisolism. Etiology include a pituitary gland tumor, Cushing disease, an adrenocorticotropic hormone secreting tumor, rarely a tumor that develops in an organ that normally doesn't produce adrenocorticotropic hormone, ectopic. A primary adrenal gland disease, the excess secretion of cortisol doesn't depend on stimulation from adrenocorticotropic hormone and is associated with disorder of adrenal gland. Familial Cushing syndrome. Rarely people inherit a tendency to develop tumor in one or more of their endocrine glands, affecting cortisol levels and causing Cushing syndrome. Iatrogenic Cushing syndrome in patients receiving long-term glucocorticoid treatment for asthma, arthritis, and other conditions. Pathogenesis. Hypertension in Cushing syndrome results from an interplay of several pathophysiological mechanisms regulating plasma volume, peripheral vascular resistance, and cardiac output, all of which are increased in Cushing syndrome. In addition, glucocorticoids may exert some hypertensive effects on cardiovascular regulation through the central nervous system via both glucocorticoid and mineralocorticoid receptors. Ultimately, glucocorticoids induce changes that increase cardiac output, total peripheral resistance, and renovascular resistance, leading to chronic hypertension. Insulin resistance and sleep apnea seem also to contribute to the hypertension of Cushing syndrome. Signs and symptoms of Cushing syndrome. Systemic changes, fatigue or hypomania, growth retardation, increased weight from baseline, insomnia, vivid dreams. Skin adipose hair, abnormal adipose in dorsocervical, supraclavicular, temporal areas. Stria, especially if more than 1 centimeter, white and purple. Thin skin, especially at less than 40 years. Hyperpigmentation, typically over joints, in scars, buccal and vaginal mucosa, and perioral. Hirsutism and balding in women. Acne, especially if new. Poor wound healing. Increased bruising. Flushed red face. Psychiatric and congenital changes. Accentuation of previous personality, psychiatric disorder. Increased irritability. Decreased memory. Decreased cognitive ability. Infectious, increased number of infections. Metabolic and renal changes, glucose intolerance and diabetes. Increased incidence of stones. Cardiovascular and thrombotic changes, hypertension, increased incidence cerebrovascular accidents. Diagnosis. Initial test to diagnose Cushing syndrome. Midnight plasma cortisol and late-night salivary cortisol measurement. 24-hour urine cortisol or urine-free cortisol. Dexamethasone suppression screening test. General laboratory test, CBC and differential, may show a high white blood cells count and increased number of neutrophils. Glucose tolerance test impaired also. Potassium level decreased, hypokalemia. Non-laboratory tests, computed tomography, magnetic resonance imaging, ultrasound, and octreotide scan. Treatment. Reducing corticosteroid use if the cause of Cushing syndrome is long-term use of corticosteroid medication. Surgery if the cause of Cushing syndrome is a tumor. Radiation therapy if the surgeon can totally remove a tumor. Medication, ketoconazole, mitotane, and metirapone. Hyperthyroidism. Definition. Hyperthyroidism occurs when thyroid gland produces too much of the hormone thyroxine. Pathogenesis. The excess of T3 leads to metabolic and hemodynamic changes. Metabolic rate, cardiac preload, and ventricular contractility increase, causing an increased cardiac output and hypertension. Hypertension appears to be more common among hyperthyroid patients. Symptoms and signs: nervousness, anxiety and irritability, hyperactivity, mood swings, difficulty sleeping, feeling tired all the time, sensitivity to heat, muscle weakness, diarrhea, needing to urinate more often than usual, persistent thirst, itchiness, loss of interest in sex, a swelling in neck caused by an enlarged thyroid gland, an irregular and or unusually fast heart rate, twitching or trembling, warm skin and excessive sweating, red palms of hands, loose nails, a raised itchy rash known as hiatus urticaria, patchy hair loss or thinning, weight loss, often despite increased appetite, exophthalmos, balding eyes, eye problems such as redness, dryness, or vision problems. This is the eye, like exophthalmos. Diagnosis: the test checks the level of thyroid-stimulating hormone is decreased, thyrotronin elevated, thyroxine elevated. Treatment: thionides and beta blockers. Pheochromocytoma. Definition: pheochromocytoma is a rare chromophene cell tumor of the adrenal medulla. When a tumor composed of the same cells as a pheochromocytoma develops outside the adrenal gland, it is referred to as paraganglioma. Pathogenesis: these neuroendocrine tumors are capable of producing and releasing massive amounts of catecholamines, metanephrines, or methoxytyramine, which result in the most common symptoms including hypertension, tachycardia, and diaphoresis. Symptoms and signs: pallor, heat intolerance, weight loss, chest and or abdominal discomfort, nausea, vomiting, constipation, orthostatic hypertension, psychological manifestation like anxiety, panic attack, nervousness, tremulous, hyperglycemia. Diagnosis: urine metanephrines testing is used to help detect or rule out the presence of a rare tumor called pheochromocytoma or a paraganglioma that release excess metanephrines. Since this tumor produces these hormones in excess, measuring the amount in the blood and or urine may help detect the tumor. Treatment: the primary treatment of pheochromocytoma is surgery to remove the tumor. Before surgery, should be prescribed specific blood pressure medication that block the action of the high adrenaline hormone to lower the risk of developing dangerously high blood pressure during surgery. Acromegaly. Acromegaly is usually caused by the pituitary gland producing excess growth hormone after the growth plate had closed. In more than 25% of cases, the excess producing is due to a benign tumor known as a pituitary adenoma. Pathogenesis. Acromegaly is frequently associated with insulin resistance and hyperinsulinemia, which may induce hypertension by stimulating renal sodium absorption and sympathetic nervous activity. Whether sympathetic tone is altered in acromegalic hypertensive patients remains a matter of debate. Signs and symptoms. Headaches, often severe and prolonged. Soft tissue swelling, visibly resulting in enlargement of the hands, feet, nose, lips and ears, and a general thickening of the skin. Soft tissue swelling is internal organs, notably the heart, with attendant weakness of its muscularity, and the kidney, also the vocal cords, resulting in a characteristic thick, deep voice and slowing of speech. Generalized expansion of the skull of the fontanelle. Pronounced brow protrusion, often with ocular distension. Pronounced lower jaw protrusion with attendant macroglossia and wide teeth spacing. Hypertrichinosis, hyperpigmentation, and hyperhidrosis may occur in these people. Skin tags, carpal tunnel syndrome. Diagnosis. Testing insulin-like growth factor 1. Oral glucose tolerance test. Imaging test to confirm acromegaly. Treatment. The most common treatment for acromegaly are surgery, medication, and radiation therapy. Surgery. In many cases, surgery greatly improves acromegaly symptoms or corrects the condition entirely. Medication. Injected medication such as somatostatin analogs can help manage hormone levels. Renal hypertension. Include one of them, renovascular hypertension. Renovascular hypertension is a condition in which high blood pressure is caused by the kidneys' hormonal response to narrowing of the arteries supplying the kidneys. When functioning properly, this hormonal axis regulates blood pressure. Pathogenesis. Renovascular hypertension can result from renal artery lesions involving the main renal artery or its branches. It is generally felt that the elevation of blood pressure results from excessive systemic vasoconstriction secondary to enhancing the renal secretion by one or part of one kidney. Signs and symptoms. High blood pressure at a young age or age more than 50 years. High blood pressure that suddenly gets worse or is hard to control. Kidneys that are not working well. Narrowing of other arteries in the body, such as the legs, the brain, the eyes, and spleen. Headache, confusion, blurry or double vision, bloody urine, nosebleed. Diagnosis. Duplex ultrasound. Images from this test can show blockage in the renal artery or blood moving through nerve arteries at a higher than normal speed. Computerized tomographic angiography, magnetic resonance angiogram, catheter angiogram, a special kind of X-ray in which a catheter or a thin flexible tube is threaded through the large arteries into the renal artery. Treatment include angiotensin-converting enzyme inhibitors, angiotensin receptor blockers, and angioplasty. Renal parenchymal hypertension. Etiology of the renal parenchymal hypertension is a form of secondary hypertension caused by kidney disease. It may occur in the course of glomerulonephritis, diabetic nephropathy, kidney damage in the course of systemic connective tissue disease like systemic lupus erythematosus, systemic sclerosis, systemic vasculitis, tubular intestinal nephritis, obstructive nephropathy, polycystic kidney disease, large solitary kidney cyst, post-irradiation nephropathy, hypoplastic kidney, renal tuberculosis. Pathogenesis. Main mechanisms leading to hypertension and chronic kidney disease include impaired urinary sodium and water excretion, excessive kidney release of vasoconstrictors, vasodilator deficiency, sympathetic activation, endocrine and metabolic disturbance. Signs and symptoms. Hypertension often develops at an early stage of kidney disease, when the glomerular filtration rate is only slightly reduced. Symptoms of the underlying kidney disease are usually the predominant clinical feature. Sodium and water retention manifest as peripheral edema only in some patients. Diagnosis. Perform the same diagnostic test as in all patients with hypertension, as well as studies necessary for the diagnosis of the kidney disease responsible for the hypertension. Treatment. Treatment of renal parenchymal hypertension involves treating the underlying kidney disease and hypertension. Restriction of salt intake. Monitoring fluid balance. Angiotensin converting enzyme inhibitors. Angiotensin receptor blockers. Polycystic kidney disease. Polycystic kidney disease is a genetic disorder in which the renal tubes become structurally abnormal, resulting in the development and growth of multiple cysts within the kidney. These cysts may begin to develop in utero, in infancy, in childhood, or in adulthood. Cysts are non-functioning tubules filled with fluid pumped into them, which range in size from microscopic to enormous, crushing adjacent normal tubules and eventually rendering them non-functional as well. Polycystic kidney disease is caused by abnormal genes which produce a specific abnormal protein which has an adverse effect on tubule development. Polycystic kidney disease is a general term of two types, each having their own pathology and genetic causes: autosomal dominant polycystic kidney disease and autosomal recessive polycystic kidney disease. Hypertension is due to the activation of the renin, angiotensin, aldosterone system. Symptoms: high blood pressure, back or side pain, blood in urine, a feeling of fullness in abdomen, increased size of abdomen due to enlarged kidneys, headaches, kidney stones, kidney failure, urinary tract or kidney infection. Diagnosis by ultrasound, CT scan, and MRI scan. In this slide you can see renal volume in polycystic kidney disease. They are very big in the both sides. There is also a big kidneys with a cyst. This cross pathology of polycystic kidney. In this slide you can see also the big size of kidneys, both kidneys with the cysts. Treatment. Careful control of blood pressure. Prompt treatment with antibiotics of a bladder or kidney infection. Loss of fluid when blood in the urine is first noted. Medication to control pain. A healthy lifestyle with regard to smoking cessation, exercise, weight control, and reduced salt intake. Drinking lots of plain water throughout the day. Avoiding caffeine in all beverage. Systemic lupus erythematosus. Systemic lupus erythematosus is an autoimmune disease. In this disease, the immune system of the body mistakenly attacks healthy tissue. It can affect the skin, joints, kidneys, brain, and other organs. The cause of systemic lupus erythematosus is not clearly known. It may be linked to the following factors: genetic, environmental, hormonal, certain medication. Systemic lupus erythematosus is associated with a high burden of cardiovascular disease, which is in part imputed to classical vascular risk factors such as hypertension. Hypertension is frequent among patients with systemic lupus erythematosus, and studies show it is more prevalent in systemic lupus erythematosus patients than in people without systemic lupus erythematosus. Signs and symptoms of systemic lupus erythematosus: malar rash, ulcer mucocutaneous involvement, renal involvement, proteinuria, urinary cellular casts, seizure, thrombocytopenia, hemolytic anemia, fever, lymphadenopathy. You can see the patient with malar rash and the skin changes in the hand. Diagnosis. Laboratory tests. The first is antinuclear antibody testing and anti-extractable nuclear antigen from the mainstay of serologic testing for systemic lupus erythematosus. If antinuclear antibody is negative, the disease can be ruled out. Other tests routinely performed in suspected systemic lupus erythematosus are complement system levels, electrolytes and kidney function test, liver enzymes, and complete blood count. Treatment: corticosteroids and anti-malarial drugs. Certain type of lupus nephritis, such as diffuse proliferative glomerulonephritis, require intermittent cytotoxic drugs like cyclophosphamide and mycophenolate. Cyclophosphamide increased the risk of developing infections, pancreas problems, high blood sugar, and high blood pressure also. Hydroxychloroquine was approved by the FDA for lupus in 1955. Some drugs approved for other diseases are used for systemic lupus erythematosus off-label. In November 2010, an FDA advisory panel recommended approving belimumab as a treatment of the pain and flare-ups common in lupus. Coarctation of the aorta. Definition: coarctation of the aorta is secondary cause of hypertension. Require careful attention to physical findings to make a diagnosis. Coarctation of the aorta is generally present at birth to the congenital. Signs and symptoms: high blood pressure, headache, muscle weakness, leg cramps or cold feet, nosebleeds, chest pain, abnormal differences in upper and lower extremity arterial pulses and blood pressure, diminished and delayed pulses distal to obstruction. Diagnosis include chest radiography, barium esophagography, classic ESI, echocardiography. In older patients, surface echocardiography may not suffice, and magnetic resonance imaging, transesophageal echocardiography, or cardiac catheterization with angiogram may be necessary. Fetal echocardiography, MRI. This test is sensitive but expensive, time-consuming, and not universally available. It is seldom used as a primary diagnostic tool. Treatment in adults. Resection of the coarctation site and end-to-end anastomosis to repair coarctation, still the preferred surgical method. Patch aortoplasty, left subclavian flap angioplasty, bypass graft repair bringing the ascending and descending aorta. Primary hyperparathyroidism, the next cause of secondary hypertension. Definition: primary hyperparathyroidism is usually caused by a tumor within the parathyroid gland. The symptoms of the condition relate to the elevated calcium level, which can cause digestive symptoms, kidney stones, psychiatric abnormalities, and bone disease. Pathogenesis: the mechanism by which primary parathyroid hyperplasia is associated with hypertension and increased cardiovascular risk remain poorly understood and somewhat intriguing. PPTH has been associated with endothelial dysfunction, which is usually due to reduced nitric oxide reactivity and represents a hallmark of high blood pressure and many other conditions that are associated with increased cardiovascular risk. Signs and symptoms: stones refer to kidney stones, nephrocalcinosis. This can ultimately lead to kidney failure. Bones refer to bone-related complications. The classic bone disease is hyperparathyroidism is osteitis fibrosa cystica, which results in pain and sometimes pathological fractures. Other bone diseases associated with hyperparathyroidism are osteoporosis, osteomalacia, and arthritis. Abdominal grounds refer to gastrointestinal symptoms of constipation, indigestion, nausea and vomiting. Hypercalcemia can lead to peptic ulcers and acute pancreatitis. The peptic ulcers can be an effect of increased gastric acid secretion by hypercalcemia. Tones refer to polyuria and constipation. Psychiatric overtones refer to effect on the central nervous system. Symptoms include lethargy, fatigue, depression, memory loss, psychosis, ataxia, delirium, and coma. Left ventricular hypertrophy may also be seen. Other signs include proximal muscle weakness, itching, and band keratopathy of the eyes. When subject to formal research, symptoms of depression, pain, and gastric dysfunction seem to correlate with mild cases of hypercalcemia. Diagnosis: blood test, calcium level in the blood elevated, parathyroid hormone level in blood also elevated. Additional diagnosis tests: bone mineral density test, urine test, imaging test of kidneys. Imaging test before surgery. System-MIB parathyroid scan. System-MIB is a radioactive compound that is absorbed by overactive parathyroid glands and can be detected by a scanner that detects radioactivity. Ultrasound. Ultrasound uses sound wave to read images of the parathyroid glands and surrounding tissue. Treatment. Surgery. Surgery is the most common treatment for primary hyperthyroidism and provides a cure in most cases. A surgeon will remove only those glands that are enlarged or have a tumor. Drugs, calcimimetics, hormone replacement therapy, and bisphosphonates. Obstructive sleep apnea. Obstructive sleep apnea is a recognized cause of secondary hypertension. Obstructive sleep apnea episode produce surges in systolic and diastolic pressure that keep mean blood pressure levels elevated at night. In many patients, blood pressure remains elevated during the daytime when breathing is normal. Contributors to this diurnal pattern of hypertension include systemic nervous system overactivity and alteration in vascular function and structure caused by oxidant stress and inflammation. Pathogenesis. Pathogenesis includes the next mechanism: inflammatory and cytokine-mediated effects of hypoxemia, activation of the renin-angiotensin-aldosterone system, negative intrathoracic pressure putting stress on the heart, impaired quality of sleep, nocturnal fluid shift, high sympathetic autonomic system, and low parasympathetic autonomic system. It is a cause of hypertension. Signs and symptoms: excessive daytime sleepiness, loud snoring, observed episodes of stopped breathing during sleep, abrupt awakening accompanied by gasping or choking, awakening with a dry mouth or sore throat, morning headache, difficulty concentrating during the day. Diagnosis: due to polysomnography, home sleep apnea testing. Treatment. Lifestyle changes, lose weight, exercise regularly, drinking alcohol moderately or not drinking at all, and not drinking several hours before bedtime. Quit smoking. Use a nasal decongestant or allergy medication. Don't sleep on back. Avoid taking sedative medication such as anti-anxiety drugs or sleeping pills. Continuous positive airway pressure. Device called a continuous positive airway pressure machine eliminates snoring and prevents sleep apnea. This machine delivers just enough air pressure to a mask to keep upper airway passage open, preventing snoring and sleep apnea. Most pies, like oral device. Thought positive airway pressure is often an effective treatment. Oral appliances are an alternative for some people with mild or moderate obstructive sleep apnea. This device may reduce sleepiness and improve quality of life. Surgery or other procedure. Surgical removal of tissue, uvula, palatal, pharyngoplasty. Upper airway stimulation. Jaw surgery. In this procedure, the upper and lower part of jaw are moved forward from the rest of facial bone. Surgical opening in the neck, like tracheostomy. Implants. This minimally invasive treatment involves the placement of 3 tiny polyester rods in the soft palate. Drug-induced hypertension. The chemical substance and medicines that can cause high blood pressure include acetaminophen, alcohol, amphetamine, ecstasy, and cocaine. Angiogenesis inhibitors, antidepressants, caffeine, corticosteroids, cyclosporine, ephedra, and many other herbal products, erythropoietin. Estrogens, including birth control pills, immunosuppressants, many over-the-counter medicines such as cough, cold, and asthma medicines, particularly when the cough, cold medicine is taken with certain antidepressants such as trimethoprimine or tricyclics. Migraine medicines, nasal decongestant, nicotine, non-steroid anti-inflammatory drugs, testosterone and other anabolic steroids, and performance-enhancing drugs. Management of hypertension. Treatment overview include goals of therapy, lifestyle modification, pharmacological treatment, algorithm for treatment of hypertension, and follow-up monitoring. Goals of therapy: reduce cardiac and renal morbidity and mortality. Treat to BP less than 140 per 90 mm hydrargyrum, or BP less than 130 per 80 mg hydrargyrum in patients with diabetes or chronic kidney disease. Non-pharmacological treatment of hypertension include dietary approaches to stopping hypertension like diet, regular exercise, lose weight or if obese, reduce salt and high-fat diets, avoid harmful habits, smoking, alcohol. Lifestyle modification include lose weight or if overweight, increase physical activity, reduce salt intake, stop smoking, limit intake of food rich in fat and cholesterol, increase consumption of fruits and vegetables, limit alcohol intake. Lifestyle modification reduce the arterial BP. Weight reduction, reduction can range 5 to 20 milliliter hydrargyrum per 10 kilogram weight loss. Adopt dietary approach, stop hypertension eating plan. It can reduce BP 8 to 14 milligram hydrargyrum. Dietary sodium reduction can decrease the BP 2 to 8 milligram hydrargyrum. Physical activity decrease BP 4 to 9 milligram hydrargyrum. Moderation of alcohol consumption decrease the BP to 4 milligram hydrargyrum. In this slide, you can see antihypertensive drugs. For example, sympathetic nerve terminated drugs, vasomotor center drugs, beta receptors of heart drugs, sympathetic ganglion drugs, and so on. Diuretics. Example, hydrochlorothiazide acts by decreasing blood volume and cardiac output, decrease peripheral resistance during chronic therapy. Drugs of choice in elderly hypertensive. Side effects, hypokalemia, hyponatremia, hyperlipidemia, hyperuricemia, hyperglycemia, not safe in renal and hepatic insufficiency. Beta blockers, atenolol, metoprolol, nebivolol, block beta-1 receptors on the heart, block B2 receptors on kidney and inhibit release of renin, decrease the rate, force of contraction and thus reduce cardiac output. Drugs of choice in patients with coexisting coronary heart disease. Side effects, lethargy, impotency, bradycardia. Not safe in patients with coexisting asthma and diabetes. Have an adverse effect on the lipid profile. Calcium channel blockers. Amlodipine. Block entry of calcium through calcium channel. Cause vasodilation and reduce peripheral resistance. Drugs of choice in elderly hypertensive and those with coexisting asthma. Natural effect on glucose and lipid level. Side effects, flushing, headache, pedal edema. Angiotensin converting enzyme inhibitors, ramipril, lisinopril, enalapril, inhibit angiotensin converting enzyme and formation of angiotensin II and block its effects. Drug is of choice in coexisting diabetes mellitus and heart failure. Side effects: dry cough, hypertension, angioedema. Angiotensin II receptor blockers like losartan block the angiotensin II receptors and inhibit effect of angiotensin II. Drug of choice in patients with coexisting diabetes mellitus. Side effects: safer than angiotensin converting enzyme inhibitors and hypertension. Alpha blockers. Prozazine block alpha-1 receptors and cause vasodilation, reduce peripheral resistance and venous return, exert beneficial effects on lipids and insulin sensitivity. Drugs of choice in patients with coexisting benign prostate hyperplasia. Side effects: postural hypotension. Algorithm for treatment of hypertension. In the first, there is a lifestyle modification. Not at global blood pressure. In this case, initial drug choice. It can be without compelling indications or with compelling indications. In stage 1 hypertension, it is most common using is diuretics. Consider also another drugs like angiotensin converting enzyme inhibitors, angiotensin receptor blockers, beta blockers, calcium channel blockers, or their combination. Stage 2 hypertension, 2 drugs combination for most, and we can usually use thiazide type diuretics and one of the angiotensin converting enzyme inhibitors or angiotensin receptor blockers or beta blockers or calcium channel blockers. With compelling indications, drugs for the compelling indications, other antidepressant drugs such diuretics, angiotensin receptor inhibitors, angiotensin receptor blockers, angiotensin converting inhibitors, beta blockers, calcium channel blockers as needed. Not at goal blood pressure. In this case, optimize dosage or add additional drugs until goal blood pressure is achieved. Consider consultation with hypertension specialist. Thank you for attention.